Hi, my name is Vicente Torres. I am a member of and former director of the Mayo Clinic Translational PKD Center, and also co-chair of the work group of the KDIGO 2025 Clinical Practice Guideline for the evaluation, management, and treatment of ADPKD. In this video, I would like to share some key takeaways for intracranial aneurysms and other extrarenal complications of ADPKD. Intracranial aneurysms constitute the most life-threatening association of ADPKD. The prevalence of intracranial aneurysms and the incidence of intracranial aneurysmal rupture causing subarachnoid hemorrhage are approximately 4 and 7 times higher respectively in ADPKD than in the general population. In both populations, the prevalence of aneurysms and the incidence of aneurysmal rupture are higher when there is a family history of intracranial aneurysms and especially subarachnoid hemorrhage. Adults with ADPKD should be informed of their elevated risk for intracranial aneurysms and subarachnoid hemorrhage. They should also be educated on recognizing symptoms like thunderclap headaches that require immediate medical attention. Next, a note about comprehensive risk assessment. A detailed family history of intracranial aneurysms, subarachnoid hemorrhage, or unexplained sudden death is crucial in identifying people with ADPKD who are at higher risk for intracranial aneurysms. Screening for intracranial aneurysms is recommended in these people at a higher risk, especially in those who are eligible for treatment and with a reasonable life expectancy. Intracranial aneurysm screening should also be considered in a specific clinical context, such as during evaluation for kidney and or liver transplantation, or prior to major elective surgery in people with ADPKD. Pre-symptomatic screening for intracranial aneurysm has advantages and limitations. Such screening may allow for intervention if an intracranial aneurysm at risk of rupture is identified, which may prevent a death or significant comorbidity. It may allow imaging follow-up if an aneurysm with low risk of rupture is identified, and reduce anxiety when no aneurysm is detected. But the screening also has drawbacks. It may lead to the identification of aneurysms with very low risk of rupture that do not require intervention but require long-term follow-up. It does not exclude the risk of de novo intracranial aneurysms, development, and rupture after screening. It may lead to procedures with possible treatment failure or complications, including death or significant morbidity. It may cause anxiety when an aneurysm is identified and may limit access to life insurance, loans, or driver's licenses and potential work opportunities. Because screening has potential benefits and drawbacks, shared decision-making is essential. After being adequately informed about the benefits and risks of screening, people with ADPKD not considered at high risk for aneurysms who wish to be screened should be provided access to screening. Next, a note about imaging for intracranial aneurysm detection. When screening is pursued, time-of-flight magnetic resonance angiography without gadolinium enhancement is recommended. High-resolution computed tomography angiography, which requires contrast administration, may be used as an alternative. In high-risk people with ADPKD and a negative initial intracranial aneurysm screening, the timing of rescreening should be individualized with intervals of 5 to 10 years depending on the risk factors, age, and life expectancy. Modifiable factors that increase the risk of intracranial aneurysm development and rupture include smoking, uncontrolled hypertension, and alcohol in large quantities. In the last decades, the risk of subarachnoid hemorrhage in the general population has decreased worldwide, likely due to less smoking and better blood pressure control. Therefore, smoking cessation and blood pressure control are critical. ADPKD is a systemic disease and involves almost every organ and tissue. Physicians taking care of people with ADPKD should be aware of these associations and address them appropriately when they are present. Presymptomatic screening for these extrarenal associations is not indicated except in families with non-ischemic idiopathic cardiomyopathies, thoracic aortic aneurysms, or coronary artery dissections. That concludes our focus on intracranial aneurysms and other extrarenal complications with ADPKD. Thanks for watching. I encourage you to explore the entire collection of videos we have assembled on this guideline. We are all very proud of this work, and we hope it will meaningfully serve both clinicians and the people we care for around the world. The full clinical practice guideline can be accessed online at www.kdigo.org.